Good evening, sir.
Good evening.
Sir, shall we start?
Okay, start.
Yes, sir. So we'll be continuing the seminar on the benign breast disorders. The topic we'll be starting with would be gynecomastia. So gynecomastia is basically hypertrophy of the male breast due to increase in the ductal and connective tissue elements, often attaining features of the female breast in a male.
It's 5 o'clock.
So gynecomastia can be physiological as well as pathological. Physiological gynecomastia is occurring during three phases of life. Firstly, the neonatal period due to the effect of the maternal estrogen. Secondly, it occurs during the adolescence when the male is passing through puberty. Thirdly, during senescence, due to a decrease in the androgen levels as the age increases. Now, gynecomastia can be unilateral or bilateral. Unilateral, it occurs in puberty, and bilateral more commonly in senescent varieties. Then, in the non-obese male, what is defined as gynecomastia is at least 2 centimeters diameter of breast tissue behind the nipple. The dominant masses or areas of firmness, irregularity, and asymmetry suggest the possibility of breast cancer, particularly in an elderly male. Therefore, it is necessary to differentiate it from uh, male breast cancer in the elderly age group. However, gynecomastia does not predispose the males to breast cancer.
So you should understand that it is not a pre-malignant condition. The importance is that will require means there is no need to do surgery for fear of malignancy. That should be conveyed to the patient. You should keep this thing in mind. You understand? So that's why it is not a pre-malignant condition or does not develop into malignancy. Because the most of the time problem is what is the surgery to be done, whether the surgery is needed or not.
Yes, sir. So, gynecomastia is graded based on the degree of breast enlargement, uh, the position of the nipple as compared to the inframammary fold, and the degree of breast ptosis and skin redundancy. It is divided into three grades, the second grade being subdivided into further two grades. The first one is that there is mild breast enlargement without any skin redundancy. There is no extra skin present, as depicted in the diagram below. This grade 2A is moderate breast enlargement without skin redundancy. There is no extra skin here as well. Grade 2B is also moderate breast enlargement but with skin redundancy. The nipple goes at the level of the inframammary fold in the grade 2B. Then grade 3 is marked breast enlargement with skin redundancy and ptosis, where the nipple areola complex goes below the inframammary fold. So the causes of gynecomastia. Causes can be basically divided into three
So
categories.
the first is word which should be used is idiopathic causes. What is that? What are the theory behind idiopathic gynecomastia?
So,
And what are the content inside the gynecomastia? Are they normal breast tissue like a female or something else?
it is the normal breast tissue, as in the
So
female.
does it have a secretory tissue also?
No, sir. There is no secretory tissue.
So
As
what is the reason for idiopathic gynecomastia?
Sir, idiopathic gynecomastia is mainly because there is excessive estrogen as compared to the androgens in the body, and
Mhm.
secretory part is not there because progesterone is basically responsible for the secretion of milk, and progesterone as is not present in the male body.
Hmm. Yes,
That's
so it's a predominantly stromal tissue, which is more. Does it have a decliferous ductules?
yes, sir. Ductules would be present.
Exactly. The word which is important, it contains of two parts. One is a secretory cell, and which kind of gland is mammary gland? You must have told last time I was not present.
It is an apocrine sweat gland.
So what is apocrine sweat gland?
Sir, an apocrine sweat gland is a gland in which the apical part of the cell is shed off along with the secretions.
Very good. So secretion is by shedding of the apical part. That's apocrine. So that part will not be there in gynecomastia, but the ductules do form, but the predominantly stromal tissue hypertrophy, which is a gynecomastia, right? That's why it is you almost always firmer than the normal breast. Always keep that in mind. And why it is unilateral, not bilateral many times, particularly when it is idiopathic.
I don't know, sir.
So what is the reason for idiopathic gynecomastia? Theory behind.
Sir, idiopathic gynecomastia, it can be due to,
Basically, there is a some breast tissue which is there congenitally. Each may be differential in each breast. Some breast has a more, some breast has a less. So idiopathic is a basically excessive level of estrogen which causes this problem, right? So it is important that one should understand that it can be a differential growth, and usually it is in a one breast that you will find idiopathy. Continue.
yes, sir. So the causes of gynecomastia can be divided into basically three categories, where there are estrogen excess states, there are androgen deficient states, and due to pharmacological causes. The estrogen excess states can be gonadal in origin or non-testicular. Gonadal would be in a true hermaphrodite. A hermaphrodite being a person with sexual organs of both the genders, ovaries as well as testes. The second one would be the gonadal stromal neoplasms of the testes, originating from the Leydig cells, the Sertoli cells, or the granulosa theca cells, all of which release estrogen and cause gynecomastia. The third category of gonadal origin would be the germ cell tumors, which form choriocarcinoma, the seminoma, the teratoma, or the embryonal carcinomas. All of these are tumors which cause release of estrogen, hence causing an excess estrogen state. Another cause is the non-testicular tumor. These include adrenal cortical neoplasms. The adrenal glands are also responsible for formation of estrogen other than the gonadal organs, hence causing an estrogen excess state. Lung carcinomas. Lung carcinomas do cause gynecomastia as paraneoplastic syndromes, as there are some categories of tumors which such as small cell lung cancer, which do release estrogen as a byproduct. Then similarly, there are the hepatocellular carcinomas, which also cause increase in estrogen states. The other are the endocrine disorders, which essentially cause excessive estrogen. There are diseases of the liver. Now, the main function of liver in this is the degradation of estrogen, hence maintaining a balance between estrogen and androgens. But in liver diseases, that estrogen is not broken down, hence yet again causing an excess state of estrogen. The third is nutritional alteration states, where the patient is malnourished or matlab, or excessively nourished, in which cases the amount of androgen is converted into estrogen by the peripheral adipose tissue. These all could cause estrogen excess states, which further cause gynecomastia. The next slide ponders upon androgen deficiency states. These include senescence. Hype. In senescence, as the age increases, it leads to testicular atrophy, thus causing a decrease in the release of testosterone. Hence, a comparative excess of estrogen occurs in this case. Other are the hypoandrogenic states, in which the androgen releasing to the capacity of the testis is hampered. These can include Klinefelter syndrome, which is typically double XY. The next is the Riefenstein syndrome, in which there is androgen insensitivity. I mean the androgen receptors do not respond to the peripheral testosterone in the blood, thus leading to an androgen deficient state. Another is the Rosewater Guinup Hamvi familial gynecomastia. The another is Kalman syndrome, which is a hypogonadotropic hypogonadism, which reduces the capacity of the testis to produce testosterone. Then another is Kennedy's disease, which is a spinal and bulbar muscular atrophy, which can be associated with gynecomastia in certain cases. Then there is a unicoidal state, where there is a congenital anorchia, absence of the testis. There can be hereditary defects in androgen biosynthesis due to absence of various metabolic enzymes. It can also be there due to adrenocorticotropic hormone deficiency, which uh, which helps in maintaining the testosterone levels via the ACTH loop pathway. Other causes of hypoandrogenic states can be due to secondary testicular failure, which can occur due to trauma. Direct trauma to the scrotum can cause decreased capacity of the testis. It can be due to inflammation, as in orchitis. Then cryptorchidism is essentially associated with a decrease in the reproductive capacity of the testis. Also irradiation, which affects the sperm producing cells, the germ cells of the testis, and decreases, also affects the Sertoli cells which produce the testosterone. The another can be renal failure, in which excessive the testosterone is lost via the renal tubules. All of these states cause androgen deficiency, which yet again leads to gynecomastia. Then another important cause for gynecomastia. Yes, sir. Another important cause for gynecomastia are the pharmacological causes, where there are various drugs which affect the estrogen and testosterone balance. There can be drugs with estrogenic activity, such as digitalis, estrogen itself, anabolic steroids, or marijuana. There are drugs that enhance estrogen synthesis indirectly. Estrogen synthesis directly, such as human chorionic gonadotropin. There are drugs that inhibit the action or synthesis of testosterone, such as cimetidine, ketoconazole, phenytoin, spironolactone, and other anti-neoplastic drugs as well. They affect the testis, the Sertoli cell, and the Leydig cell system, and they decrease the synthesis of testosterone. Then there are other class of drugs whose exact mechanism for causing gynecomastia has not yet been understood well. These are the idiopathic ones: the risperidone, theophylline, verapamil, tricyclic antidepressants, as well as furosemide. All of these drugs can cause gynecomastia in certain individuals, and the treatment for these would be to stop these drugs if that is feasible for the patient. Now, clinically, the patient would present with a small, well localized, firm swelling below the areola, which can be painful and tender in some cases. Now, it should be excised when symptomatic being painful or tender. But the main problem with gynecomastia comes as in the form of embarrassment for the patient. He feels socially awkward, and that leads to much distress for the patient, in which cases also it can be excised. The differential diagnosis for gynecomastia would be pseudogynecomastia, in which there is just deposition of adipose tissue as a part of obesity, and there are no lactiferous ducts or the tubules present. There is just adipose tissue which can be treated by liposuction. There can be pectoral muscle hypertrophy, in which the pectoralis muscle lying deep to the breast tissue becomes hypertrophic and mimics gynecomastia. There can be a local lipoma, a dermoid, or even a hematoma due to various reasons, which can mimic gynecomastia. Now, the treatment part. Now,
So,
gynecomastia,
so Anik,
yes, sir.
uh, what is the main moral of the story of your such a descriptive gynecomastia? What you should understand?
Sir,
The
firstly,
basically you should remember two things.
yes,
One
sir.
is a idiopathic part which occurred around puberty or rarely at the time of menopause. Understand this point. There may be a spot of estrogen leading to this one, and it does not have a support of progesterone, so there will not be development of secretion. And
Yes,
second is any disease or a drug which causes either increased level of estrogen or a decreased level of
testosterone.
androgens will cause the gynecomastia. You said about true hermaphrodites. What about the pseudo? Will it cause gynecomastia?
Sir, pseudohermaphrodites may or may not present with gynecomastia, depending on the comparative levels of estrogen and androgen present in their body.
What about testicular atrophy?
Sir, testicular atrophy can present with gynecomastia.
So you should all remember causes of testicular atrophy. It can be a liver disease, direct trauma, bilateral hypogonadism. And those are the common causes for surgeon rather than those syndromes which are very rare,
Yeah.
right?
Yes, sir.
Okay. And the differential diagnosis in a fatty patient, particularly at the time of puberty, it may not be a gynecomastia, but still look like gynecomastia. What you have said, deposition of adipose tissue. There you should be careful before operating because the results will be very poor. Okay, now the treatment part.
Yes, sir. Now, well localized type, which is symptomatic or the patient is psychologically distressed, can be treated by surgical excision using a circumareolar incision. Now, but in cases of large diffuse gynecomastias, the submammary incision is needed, which is known as the Gaillard-Thomas incision, to excise the breast tissue.
Gilead Thomas, Gilead Thomas,
Yes,
right?
yes,
But
Gaillard.
remember, for gynecomastia, it is not a good incision. Though books say so, it is not a good incision. Usually, there are different type of incision. What are those? Gilead Thomas is usually for sometimes in a grade 4. Otherwise, there is no need to put a large Gilead Thomas because the patient's worry is a cosmetic purpose. If you put a Gilead Thomas incision in male patient, it will not be hidden by breast. Do you understand?
Yes,
In a
sir.
female patient, it will be hiding the breast, but in male, it is not possible. So it is not a good incision,
Yes, sir.
right? You should understand. So which are the incision? There are usually two incision which are put. One is a periareolar if the gynecomastia is grade 1 or grade 2A without any sagging of the breast. Or second incision,
Sir, can we approach it through the anterior axillary fold?
yes, excellent. That is the incision along the anterior axillary fold and go behind the breast tissue and remove it from inside. Because our aim in a patient of gynecomastia is partially cosmetic, should be kept in a mind. So that is the two incision, Gilead Thomas grade 4 sometime, right? But still, cosmetically, for a male patient, Gilead Thomas is not a good incision. Okay,
Yes, sir.
continue.
Other surgeries which can be done is reduction mammoplasty. There are also nipple reduction surgeries present. Then, on the conservative side, various drugs can be given to either decrease the estrogen levels or increase the androgen levels. Namely, tamoxifen, clomiphene is used. Androgen can be given themselves. Danazol, which is a pro-androgen drug. Testolactone, which is an aromatase inhibitor, is used, but it is less useful. Now, in cases of gynecomastia, drugs are given only for 6 months, in which gynecomastia for more than 2 years duration is less likely to benefit from these drugs, and surgical intervention is the mainstay of the treatment. Another modality can be breast irradiation, which is used to prevent gynecomastia in prostatic cancer who are on estrogen therapy. In these cases, the breast tissue is irradiated to prevent further formation of gynecomastia due to the estrogen therapy. Then the causative drugs, they should be stopped if they can be stopped. The testicular tumors, hyperthyroidism, they should be treated if they are the causes. The testosterone can be given if hypogonadism is the cause. Direct testosterone administration here. Endoscopic assisted subcutaneous mastectomy is done and under trial mainly for cosmetic purpose, uh, to to form as much less scar as possible.
Any other surgery, Anik?
I don't know.
Liposuction, you mentioned it somewhere.
Like, yes, sir. Liposuction would be used for pseudogynecomastia, the deposition of adipose tissue.
But can be used for gynecomastia also. How?
Liposuction can.
So it is a combination of surgery. You remove the fatty part by liposuction, then put small periareolar incision and remove the part of the fibrous part. That is also. Okay, continue.
The next benign breast disorder is an inflammatory one, namely mastitis, the inflammation of the breast tissue. It is divided into three types: the subareolar behind the areola, the intramammary within the breast tissue, and the retromammary or the submammary on the lower half of the breast tissue. Now, subareolar breast mastitis is an infection under the areola due to cracks in the nipple or in the areola itself. It results from an infected gland of Montgomery or a furuncle of the areola, which leads to blockage of the ducts of these glands, often associated with duct ectasia, which is ductal dilatation, which leads to formation of abscess, sinus, or fistula, as discussed in the previous lecture. It now subareolar mastitis is common in non-lactating women as opposed to intramammary mastitis, which is fairly common in lactating women. Risk factors for subareolar mastitis are diabetes, smoking, nipple cracks themselves, which predispose the female to further infections. Clinically, there is a red, inflamed edematous areola with a tender swelling directly underneath it. There might be nipple retraction due to surrounding fibrosis, but it is not necessary. Differential diagnosis would be Paget's disease of the nipple, as it also causes localized inflammation of the nipple areola complex. Treatment wise, under the cover of antibiotics, pus is drained by making a local subareolar incision to drain for drainage. That would be the subareolar mastitis. The next is the intramammary mastitis, which is also known as breast abscess. Now, these are of two types, depending on the lactational status of the female. It can be lactational or non-lactational. Lactational occurs up to 6 months of lactation period, and it occurs fairly in 3% of breastfeeding mothers. The precipitating factors are a cracked nipple, which makes a pathway for the entry of various microorganisms, improper cleaning of the nipple. There might be stasis of milk in cases when the baby is not feeding properly. There might be transmission of infection directly from the mouth of the baby. Clinically, there is a continuous throbbing pain in the breast and high grade fever in these cases, diffused redness, tenderness, and warmth and brawny induration in the breast, which is well palpated. Purulent discharge can be seen from the nipple in some cases, and there are also cases in which the entire breast may get involved eventually. Now, in short, there is a tender, fluctuant swelling. Ulceration and discharge can occur at a later period in long-standing cases, and lymph nodes may get enlarged in the long run and may become tender due to pus. Differential diagnosis would be inflammatory carcinoma of the breast, which is basically type 4D of the TNM staging. Now, to investigate these, first of all, we perform a blood counts, which would give a raised total leukocyte count. We go for ultrasound breast to identify the abscess in the form of a hyperdensity, its location, size, and if it is loculated or not. US ultrasound guided aspiration can also be done, and the pus should be sent for culture and sensitivity to look for any resistant organisms and to start the antibiotics accordingly. Treatment wise, we have to give antibiotics for sure. Cephalosporins can be given, flucloxacillin and amoxicillin. Basically, the penicillin group is used in these cases. Repeated ultrasound guided aspirations can be tried. These avoid surgery and scar, but these lead to a lot of recurrences. Now, the mainstay of treatment would be drainage under general anesthesia, in which a counter incision may be needed. A counter incision for the drainage of pus along with gravity. Now, in cases of intramammary mastitis, the breast abscess, these if the antibiotic coverage is given for a long time, there may be antibioma formation. There may be sinus or a skin necrosis, a milk fistula formation, or a recurrent infection which may exacerbate and lead to bacteremia and septicemia. Then another type is the non-lactational abscess of the breast. Non-lactational abscess is fairly common in ductectasia and periareolar infections, in which the common organisms are the anaerobes, the bacteroids, the anaerobic streptococci, or the enterococci and the gram-negative organisms. Whereas for mastitis, the most common organism would have been staphylococcus. Now, non-lactational abscess of the breast, it is commonly recurrent with the tender swelling under the areola and common in patients with diabetes mellitus and on immunosuppression. Treatments Treatment would be antibiotics, repeated aspiration, drainage, and later cone excision of the duct, as it is fairly coincidental with duct ectasia. The third type is the retromammary mastitis, which commonly occurs due to tuberculosis of the intercostal lymph nodes or ribs beneath or suppuration of the intercostal lymph nodes. Empyema necessitans or infected hematoma in the chest wall also is the cause. Now, presentation wise, it would be associated with pain and swelling in the chest wall, but it would be deep to the breast tissue, which is non-mobile. It would not be mobile with as we move the breast tissue. Investigations would be, it would raise all the inflammatory markers. The hematocrit would suggest an inflammation. ESR would be raised. Peripheral smear would show a raise in the neutrophils. A chest X-ray might show a hyperdensity in the form of a localized abscess. Ultrasound of the breast and chest wall can also be used to identify the location and the size of the retromammary mastitis. But here, CT scan chest is the ideal modality, which shows the extension uh, of the mastitis as well, if it is occurring as an extension of the intercostal lymph node or uh, from the ribs beneath or exactly where it is. For treatment, the cause has to be treated. For example, it is commonly due to tuberculosis, so AKT would have to be started. And drainage can be through submammary or retromammary incisions is done. Now, antibioma formation. Antibioma is basically a complication of the intramammary abscess. If intramammary mastitis is not drained and only treated by antibiotics, the pus localizes and becomes sterile with a thick fibrous tissue cover around it, which is formed by the normal tissue to localize the abscess itself. And it is called as an antibioma. No, in an antibioma, there would definitely be a previous history of mastitis, which would be treated with antibiotics and without any drainage or aspiration. Swelling here would be painless as it has become sterile. It would be smooth, non-tender, hard, and fixed to the breast tissue without involving the pectorals or the chest wall. Now, the differential diagnosis for an antibioma would yet again.
It's not necessarily that antibioma is not either to the pectoralis major muscle or sheath. See, antibioma is a abscess which is now becoming sterile collection.
Yes, ma'am.
Because of the patient has taken antibiotic, that abscess which becomes sterile. So it is just like a cold abscess, but it is not a tuberculous abscess. So when patient gives typical history of redness, inflammation, or patient is lactating, or patient is having history of trauma which is followed by redness, and now patient has taken antibiotic for 10 days and now patient comes with the swelling, your first diagnosis will be antibioma, right? So when you get USG of that patient, USG will show that there is a collection. It is a hypoechoic shadow. So it requires drainage, right? It is not like that in antibioma, you will treat conservatively, as you have said previously. So I have to interrupt it. Okay, continue.
So the differential diagnosis for an antibioma would be carcinoma breast, namely serous carcinoma of the breast. Investigations, if we can do FNAC, which leads to aspiration of various inflammatory cells and the maybe dead microorganisms. Mammography can be done, and ultrasound breast, which would show hypoechoic mass within the breast tissue. For treatment, it is necessary to either drain or excise the whole antibioma, and later
Yes, when will you excise this whole antibioma? When it becomes too much thickened wall. It is very hard swelling and too much thickened wall, just like in one quadrant, that it is occupying almost one quadrant. And it is thick walled and you have doubt about the diagnosis. These two things. Then it requires excision, right? Because if you drain and this is thick wall, will remain there and there will be a continuation of the inflammation, which has already developed a fibrosis. When patient comes after 1 month, 1.5 month, 2 months, then it is a thick walled inflammatory wall. So draining will not suffice in that case. Sometimes it may require removal of that fibrous tissue also. Okay.
yes, ma'am. And it should definitely be sent for histology, as a differential of it would be carcinoma breast. The next part is the post radiation therapy complications. Now, radiation therapy is typically given for during breast conservation surgeries, and it also leads to inflammatory changes of the breast. Thus, it can cause three groups of diseases: in the early phase, in the intermediate phase, which is months to years, or later in life after more than 10 years. In the early phase, there would be skin thickening with breast edema, where there is the localized collection of fluid and thickening of the skin over the breast. There might be fat necrosis. There can be dystrophic calcifications, which are all these three are localized to the breast. Other than that, they can affect the lungs as well. There can be radiation induced pneumonia or even reactive pleural effusion in these cases.
Have you written treatment of all these things?
No, ma'am, I've just mentioned these things.
So how will you treat? There is a skin thickening with breast edema. How will you treat?
I don't know, ma'am.
Okay. So if patient is having skin thickening with breast edema, do not require any treatment. Only you have to counsel the patient that this will remain and this will go slowly. Only massage is helpful.
Okay.
When there is no other skin changes, only edema is there and thickening is there. It is a lymphedema also because of this little bit fibrosis there. And so massage is done as per the requirement. In a lymphedema of the upper limb, what we do, we advise massage rather than going towards the axilla. Massage should be toward the inguinal region and the neck region because lymphatics to the axilla is blocked, right? So it is to be drained other lymphatics. So that skin area is to be, so by massage is given in the different area. That is one thing. If there is a little bit burning only, it requires local application of emollients. You have to explain the patient to keep thin cloth which is wet into the cold water and they apply there whenever they are feeling burning like sensation. So that thin cloth soaked into the water gives good feeling to the patient. Third thing is when there is a more burning, it is recommended by Ayurvedic people and done by the surgery department, few surgery department also, the cold leaves of the cabbage that is used to apply that gives false sense of feeling better. Because of the application, there is a counter irritation type of feeling, and that reduces little bit inflammation. So that is the most important thing, post radiation skin problem. If there is a more itching and there is a scabs formation, then it requires calamine lotion, just as we give in all other patients, and antihistaminics. Fat necrosis can be managed only if it is producing hard mass. It may require excision, or if calcification occurs, requires excision.
Exactly.
Calcification requires excision with STG also if it is larger area, right? So that occurs after that. Okay.
And then during the intermediate phase, there can be skin retraction with breast fibrosis. There can be
So
glandular.
this skin retraction can be treated after that by oncoplasty. See, sometimes if it is a localized skin retraction, the oncoplasty is done, and for that people use this fat surrounding the breast. If it is a perforators which is lying at the abdominal wall, so that fat is utilized. Retromammary fat is utilized, and that part of the fibrosed area is excised, particularly in a patient in which radiation is given after the breast conservative surgery. So that fat is replaced there. Okay.
There can be glandular atrophy in these cases,
Mhm.
which which would lead to lactational difficulty in the future as the due to the atrophy of the glands.
Yes.
There might be overlying bone fractures, as these would cause the destruction of the osteoblast and osteoclastic activity, which causes disturbance in the
So bone fractures will be of rib fracture.
rib fractures. Yes,
Rib fracture. You are giving radiation there only.
the local
It will be a rib
fracture.
fracture. A rib fracture, if it is following the radiation, will not heal. So sometimes it may require removal, supporting it. If it do not heals, then you have to give analgesic for a longer period, right? And
Yes.
if patient is having severe pain, it may require bone graft also. But people are not doing bone graft routinely. Okay.
There can be pulmonary fibrosis due to the radiations or pericardial diseases. So in the late
Pericardial disease is pericardial
there can be pericardial
effusion
infusion,
mainly.
can be pericardial infusion.
Hmm.
Then in the late phase, there can be any cardiomyopathy, such as restrictive cardiomyopathy due to fibrosis in the heart muscles, or there can
Yes.
be various radiation-induced malignancies as well.
What is the latest method for cardiomyopathy giving rise to ventricular aneurysm? Just of the subject. One question.
Latest method.
What is the surgical treatment for ventricular aneurysm after cardiomyopathy, after MI?
I don't know now.
So if there is a ventricular aneurysm, proline mesh is used to support the heart. After reducing this aneurysal part, proline mesh is kept, and it is this left ventricle is surrounded with the proline mesh, and just like we do in incisional hernia, the ventricular aneurysm is sutured, means surrounding it is a mesh is sutured surrounding the aneurysm. Okay.
The next
Which
is
are the radiation-induced malignancy? You have written radiation-induced malignancy.
these can be various squamous cell carcinomas, either of the lung or of the skin tissue. Radiation
Okay.
typically
What else?
it
You
can
take that history in lymphoma.
it can cause a lymphoma.
A small cell tumor of the lung and the lymphoma can occur.
Can also
10 years back, if patient has taken the radiation, after 10 years, patient may develop lymphoma. Okay.
Then there is the Zuska's disease, which is also known as a recurrent periductal mastitis. Now, the periductal mastitis was seen typically in ductal ectasia, and if it in cases it is recurrent, it leads to retroareolar infection and abscess formation, which may lead to complications like fistula formation, as is depicted in the figure below. And similar to ductal ectasia, where smoking was implicated as a risk factor, here also smoking is a risk factor, and it is managed symptomatically by antibiotics coupled with incision and drainage as necessary.
So initially, if patient is having this type of sinus formation or abscess formation, initially antibiotic works. But if patient is having recurrent attacks or patient develops sinus formation, then it is treated same as the ductectasia.
Yes.
Okay. Sometimes we have seen that this duct which is producing ductectasia here, it may be dilated into the breast. Because of this type of recurrent inflammation, that duct gets, patient may have simultaneously fibrocystic disease. So that duct goes into the breast tissue also, right? And that dilated duct into the breast tissue is to be removed also simultaneously. Okay.
The next disease is the Mondor's disease, which is typically thrombophlebitis of the superficial veins of the breast and anterior chest wall, although it may occur on any part of the body. It, it is a thrombosed subcutaneous cord-like structure which is usually fixed to the skin. Over the breast, it is commonly due to the thoracoepigastric vein or the lateral thoracic vein or the superior epigastric veins which are involved. It is a self-limiting disease without any recurrence, complication, or deformity, and treatment is not generally required. But it is treatment if if the patient asks for treatment, we can suggest the patient to restrict arm movements, to use to have proper breast support, and to use anti-inflammatory drugs if it is associated with pain. Now, this condition usually subsides within a few months without any recurrence or complications. There have been cases.
What are the causes for developing superficial thrombophlebitis?
Superficial thrombophlebitis.
Commonest causes.
It can be due to recurrent trauma to the superficial veins.
Okay. So if person is working in factory and using the leg, then if there is a repeated, it is a vibrating instrument, then it may give rise to thrombophlebitis of the superficial veins of the leg, right? So that is one thing. But whenever any patient comes with superficial thrombophlebitis, first thing should come in a surgeon's mind is pancreatic malignancy. It may be a presentation of the pancreatic malignancy. So this Mondor's disease is usually occurring in younger age group of the patient. But when patient comes to you, that you must investigate this patient for any mass seen into the pancreas. So USG abdomen is to be done as a routine investigation because it is a superficial thrombophlebitis. And if it has occurred as a routine in examination, you find out patient is not having much complaint and you have seen the patient, then you have to also see for the any clotting deformity. Why patient develops this thrombosis without any cause, without any trauma unknowingly. So those patients should be also investigated for hemolytic workup also.
It might also
as a surgeon, you have to investigate for these two things. If these two things are normal, you have to say patient that this patient you do not require any other things, but don't take it so lightly, right? Always investigate the patient. Treatment is no treatment. Only if there is more pain, then you give anti-inflammatory, otherwise not. We also use thrombophobe ointment for application over it.
Local
So
heparin.
it resolves it little bit faster, but it has not much role. It is just like placebo. But for patients concern, you can give thrombophobe ointment. Okay, next.
The next is a galactosele, which is typically seen in lactating women. It is a retention cyst in the subareolar region due to blockage of the lactiferous ducts. It can be seen in after cessation of breastfeeding of the child up to 10 months of time. Now, a galactosele typically contains milk and epithelial debris within. It is a soft, a large, smooth, fluctuant lump, which is usually unilateral as it is due to blockage of a specific lactiferous duct. Now, if a galactosele gets infected, it can lead to formation of an abscess. In cases of calcification, these might mimic breast carcinoma. Now, for in cases of galactosele, we go for aspiration, which would typically show a thick, creamy, greenish brown fluid, which would confirm the diagnosis of a galactosele. And for treatment, aspiration is therapeutic as well as diagnostic. We can go for excision in cases of a large galactoseles, and if it is infected, we have to go for incision and drainage of the abscess as well.
So patient will be lactating or non-lactating. That is the first thing.
It is typically seen after cessation of lactation.
Yes, that is important. So patient for female is usually not lactating, and galactosele develops. So what happens when they are ceasing the breastfeeding? They are giving breastfeeding at the night time only initially. So what happens? The milk formation occurs, but because it is not evacuated out properly, and some epithelial cells which will block this duct, there will be a collection. So initially it may be a very small swelling, which is not noticed by the patient.
Yes,
That slowly and progressively increases. So whenever you see such patients, it will not be a very small swelling beneath the areola or into the breast. When patient comes to you, usually because it is a lactating breast, so it is a large breast, and they are not able to feel this because it is, as you said, it is a soft swelling initially. Then it becomes, when it is tense, it becomes hard. So at that time, when it becomes hard, they feel that swelling and they come to you. So galactosele is diagnosed when they have seized, or there is a one duct is blocked, but patient is not having pain at that time, or patient is not giving breastfeeding on that side because of cracked nipple, and then there is a slow mini collection on one side of the breast. So in that case, this galactosele happens, and when diagnosed, it is duct is dilated, and so wall is just like a cyst. Slowly duct gets dilated, and so wall is just like a ducts, and so it is a thick walled cyst sometimes, and so it requires excision. If it is infected, then it requires IND, right?
yes.
Okay.
The next one is the traumatic fat necrosis. It typically occurs either,
How will you differentiate this traumatic fat necrosis from the galactosele?
ma'am, a traumatic fat necrosis would be smooth, just like galactosele, but it would be hard. And a
Yeah,
typical
that is important. This fat necrosis will be a very hard swelling, and it is chalky like fluid inside. And in this galactosele, it is a little bit thinner fluid.
yes, ma'am. And also
Yes.
a typical history of trauma to the breast tissue would be present in traumatic fat necrosis.
So
Now,
it
What is
may be in a
what is
lactating mother.
typical
It
history?
may be in a.
What is typical history? What will be the typical history in traumatic fat necrosis? You say typical
So
history of
I was asking the same question.
there would be history of trauma to the breast tissue. I mean,
Typical trauma. Which type of trauma?
there might be due to seatbelt injury in case I don't know.
Usually, mother says that બાળકનું માથું વાગે. Do you understand Gujarati?
Yes, ma'am. I understand.
હા, કે બાળકનું માથું વાગી ગયું છે. Patient gives that typical history. Trauma by baby.
That is a very typical history, and that's why it is important to differentiate it from galactosile or breast abscess, right? So usually when old teaching was there, we used to teach three things: how to differentiate traumatic fat necrosis from chronic abscess from malignancy. Because these three things usually you will be confusing one with the another. The important history is because the point is that even in malignancy, patient will give sometime history of trauma. Okay, that baby is head, and then patient notice, yes, there is a trauma. So how will you differentiate between these three?
Sir, abscess would be typically associated with features of inflammation.
Chronic abscess I am talking about.
Sir, I don't know.
The one is a previous history of acute abscess in past, history of taken antibiotic, that is a chronic abscess. Do you understand? There will be some redness of skin and recurrent increase and decrease in size of swelling. Remember, chronic abscess and traumatic fat necrosis will have a decrease in size of swelling. That is the most important point you should remember. The malignancy will never have a history of reduction in size of swelling. So history of reduction of swelling is definite. That usually you should think of traumatic fat necrosis will be smooth, hard. Chronic abscess will be irregular, maybe hard, maybe variegated constituent, right? But the previous history of fever is a very significant to rule out chronic abscess from traumatic fat necrosis. One more point: breast abscess usually occurs in a periphery of breast. Traumatic fat necrosis occur comparatively central of breast. Okay.
Yes, sir. So, traumatic fat necrosis would be non-progressive and non-regressive, and performing in FNAC, typically chalky white fluid with fat globules would be aspirated, and mammography would have to be done to rule out malignancy in these cases. The treatment modality would be excision of the mass, and traumatic fat necrosis is typically due to release of conversion of triglycerides into fatty acids due to trauma, which further reacts with calcium present in the milk and undergoes the saponification reaction to form a hard lump in the breast tissue.
You have written non-progressive, non-regressive. Is a non-progressive is fine, but patient many times gives history that it may have decreased over the period of time. And a second important point is it will be relatively painless. Always remember, whereas the chronic abscess will be having a pain.
Okay, sir.
But treatment is same. Mammography is mandatory, right? It is a very important that mammography, and if you are suspecting malignancy, go for true cut. If you are suspecting abscess or fat necrosis, go for FNAC. That is the right. But at the end, all three will require excision at least. That should be kept. There is a very rarely conservative treatment for any of this.
Okay. Yes.
Continue.
Yes, sir. That commences the seminar on the benign breast disorders.
The one thing I wanted to discuss, you have not included is, have you included? I don't know whether I was absent in between granulomatous mastitis.
No, sir. I have.
So that is the one in a recent time that should be included there. That is a granulomatous mastitis. Everybody should read about it. And second is a MOTT. Their presentation is different. Their management is different. The mainstay of management of granulomatous mastitis will be steroid after particular biopsy. And the recurrence is very common in granulomatous mastitis. And second important is MOTT, mycobacteria other than tuberculosis, which has becoming more and more common. Okay, thank you.
Thank you, sir.
Thank you.
Thank you, ma'am.